The inner lining of a healthy human colon is a pristine biological canvas. It forms a smooth, continuous wall that facilitates digestion and waste removal. But occasionally, that smooth surface is broken by the sudden, silent emergence of a physical anomaly. We call these growths colorectal polyps. They are extra clumps of cells that build up and form directly on the inner walls of the large intestine or the rectum. The vast majority of these growths are entirely benign. They sit quietly on the mucosal lining and pose no immediate threat to the patient's health. However, specific types of polyps follow a different trajectory. Over the course of several years, they possess a dangerous potential to slowly mutate into colorectal cancer. This creates a unique challenge for medical professionals. Visually discovering a polyp during an exam is only the first step. The critical work lies in accurately calculating whether that specific growth is a harmless false alarm or a ticking clock. To calculate that threat level, doctors rely on pathological classification. By evaluating a polyp's microscopic cellular architecture, they can accurately determine its true malignant potential. This diagram maps neoplastic precancerous polyps. Adenomas are the most common. Tubular adenomas feature tube-like structures, carrying the lowest risk. Villous adenomas shift into long, finger-like projections, with significantly higher risk. A tubulovillous adenoma blends both for an intermediate risk profile. Beyond adenomas lies the serrated pathway toward malignancy. It gets its name from the distinct sawtooth pattern these cells form under a microscope. Hyperplastic polyps fall under this sawtoothed category. They are usually small, develop in the lower colon, and carry virtually zero malignant potential. Sessile serrated adenomas, however, are the stealthy and dangerous variant. They lie perfectly flat against the walls of the upper colon, making them incredibly difficult to spot during a routine check. A polyp's hidden malignant potential is dictated by these microscopic patterns. Without a pathology lab to read them, physical appearances can be deceiving. That deception is especially true for non-neoplastic polyps. These are the false alarms of the colon, growths that take up physical space but lack any ability to turn into cancer. Inflammatory polyps, for example, are common in patients with inflammatory bowel disease. They aren't true growths, but physical byproducts of chronic inflammation and natural healing. Hamartomatous polyps are similarly benign. They are simply disorganized masses of normal tissue, though they can sometimes be linked to rare genetic syndromes. While microscopic makeup tells a pathologist what a polyp is, doctors also evaluate its macroscopic shape, its morphology. This clear illustration compares the two primary shapes. Morphology simply describes how a polyp structurally attaches to the bowel wall. On the left is a pedunculated polyp. It grows entirely on a distinct, mushroom-like stalk. On the right is a sessile polyp. It is much flatter, sprouting directly out of the mucosal wall without any supporting stalk underneath it. That physical shape directly impacts the surgical response. A distinct stalk gives doctors a clear target to easily snare and remove, while a flat, sessile growth requires far more precision to safely detach during an endoscopy. Once a polyp is safely removed, a pathologist evaluates it against strict criteria. The results calculate the patient's future risk and determine the exact timeline for their next screening. This dashboard tracks the specific red flags. First is size. Any polyp measuring 10 millimeters or larger immediately triggers a high-risk classification. The second feature is histology. If the lab detects those complex finger-like villous components we examined earlier, the risk profile jumps. The third feature is the presence of high-grade dysplasia. This classification means the cellular architecture is severely abnormal and highly disorganized. It is a biological state dangerously close to crossing the line into cancer. The fourth feature is quantity. Discovering 3 or more adenomas during a single baseline colonoscopy constitutes a high-risk event, regardless of their individual sizes. Meeting even one of these high-risk criteria sharply escalates the patient's threat profile, proving why strict, regular monitoring is an absolute necessity. Because early-stage polyps rarely cause symptoms, they grow in total silence. That makes regular screening via colonoscopy the absolute gold standard for interception. The clinical intervention is highly direct. A doctor locates the precancerous polyp, loops a snare around the tissue, and excises it entirely. That physical removal halts the adenoma-carcinoma sequence. The chain of mutation is broken before it can progress any further. This structured grid maps the vital framework doctors use to navigate colon health, categorizing growths as neoplastic, serrated, non-neoplastic, and high risk. Understanding the microscopic anatomy of these threats gives medical professionals a precise map of the danger. It empowers them to intercept cancer long before it begins, proving that early detection saves lives.